Thanks for coming in to talk about total hips today. Before I come into the office and examine your hip and go through any questions you might have, I wanted to talk to you a little bit about the specifics of the hip replacement we're going to do. As you know, we've talked about the direct anterior approach. That approach is going through the front of the hip, basically through the groin, and getting at the hip joint from the front. The traditional approach was going in the back, making a bigger incision in the buttock and addressing the back of the hip. The posterior approach, as that's called, damaged muscle and throughout its history of use in the U.S. has had a high chance of problems. Studies show that up to 4% in the best studies and as many as 7% in some studies of these hips can dislocate. 7% is 1 in 13. That makes the patient unhappy, that makes the surgeon unhappy. So over the years, change has been made to the way hips are done, and the most recent advance takes that incision right through the front of the hip with only about a 4-inch incision. The actual decision making about total hip replacements has evolved over the last several years as well. If you know people that had hips done in the 90s, they could fail. There are hip revision surgeries, and people were told their hips might last 15 to 20 years. Current state-of-the-art shows that these hip implants last much, much longer. Currently, the hip design I use, which looks something like that, we have 19-year follow-ups on the femoral stem, which is this device. We have 7-year follow-ups of the ceramic femoral heads, that's this pink device. And we also know that the mesh metal implants on the cup, when the bone grows into that, it does not loosen. So the types of hips we're putting in today are much improved from even 15 years ago. While we're not ready to tell people that hips last their lifetime, we have good data that puts in the 20 to 30 year range, maybe beyond. Currently, the hips consist of 4 major parts: the stem, the femoral head, the acetabular liner, which is this plastic liner, and the metal cup. When you do a hip replacement, you basically cut off the femoral head. The stem is placed down to the canal, leaving the hip. On the socket side, we ream open the cup to fit whatever your size is. There's a metal back cup that impacts into place, and usually it'll have 1 or 2 screws. It has a plastic liner. The outcomes from the plastic liner ceramic head is currently what we think is the state of the art, and it has a very good outcome. Other issues that have to do with total hip replacements besides dislocation include wear, and the ceramic head plastic liners give us long-term wear. There was a study done just a couple months ago that looked at wear over a 5-year period of the newest types of plastics. That was down in the 8 to 10 microns in 5 years. That's the thickness of a couple of red blood cells. So that's very, very low wear. If that wear continues throughout its lifespan, we're talking 50 to 100 years of wear on the plastics. So we think the plastics issues are solved. The ceramic heads don't wear. They're super slippery. When we do a hip replacement, because we can alter the length of the leg, that's an important consideration in surgery. The direct anterior approach also gives us a lot better control over leg length. We think reliably we can be within plus or minus a 1/4 inch, and that's our goal. Because we're not damaging muscles in the back of the hip, we don't have to limit sitting, flexing, tying your shoes, crossing your legs, all the things that get restricted when you have a posterior approach. Therefore, the post-op activities have much fewer restrictions. We don't love it if you run, because we still think that there's some possible wear on the plastic, but I'll let people ski, water ski, ride a horse, ride a snowmobile, ride a 4-wheeler, all the things that used to make us worry when we did a posterior approach. The only remaining issue about the anterior approach is that it does make an incision right there in the hip. There's a nerve that comes off the top of the pelvis, and it feeds the anterior skin on your thigh, basically roughly the shape of your front pocket in your jeans. That nerve gets injured about 10% of the time. Its location is close to the hip, and if it's injured, there is some numbness on that skin. There is no muscle innervation from this nerve, so there's no limp, there's no long-term problems. But particularly men who tend to keep their keys in their front pocket notice that it's a little numb when reaching it out of the pocket. That's really the only major complication, and as I said, that's about a 10% risk. Infection is a disaster, but that's very rare, about 3 per 1,000. That means 2 full operations to get through the infection, pull the old hip hardware out, put in new hardware. So we'd love for that never to happen. We take lots of precautions. Total hips have been used since the 1970s. Every decade shows substantial improvement to the point now where we have great faith that these devices are 25 years or longer. I appreciate the chance to talk to you about total hips. We'll have a chance in the future to talk about this in some more detail. Write down your questions. I'll want to make sure I answer every question you have before you put yourself through such a major life-changing surgery. But the goal for us is to make that change healthy, get you back enjoying life.